the dropped IOL. Good evening. I'm Ayman Madanat from Jordan. Let me start by thanking the Mayom Group, Dr. Muhammad Al-Amri, and the organizing committee for inviting me to this esteemed meeting. Let me also thank our panelists, my dear friends, Dr. Salam, Dr. Abdul Aziz, Dr. Rao. Thank you very much. It's always good to see our old friends. This one? Well, every one of us at one stage, we will be met with a dropped IOL in some of his patients. Well, this is a case of dropped IOL that was referred to me. Can you put the bit music down? You can see there is vitreous hemorrhage, there is dropped IOL. Now, you have this problem. You have to solve it by removing the IOL, making sure by doing a proper vitrectomy. You have to check your retina that there is no tears, no holes, nothing. And you have to fix the problem of aphakia. I'm going to go through all these steps and show you what do I do. Now, before removing the IOL, you have to clean all the vitreous around it. Otherwise, if you are going to pull, you might cause a retinal tear. So you have to remove all the vitreous around the IOL. Then when it's free, you can take it out. This case, as you've seen, looks like an extra cap. In fact, it was started as phaco, and the surgeon has in fact converted it into an extra cap at one stage. I removed the lens through the anterior chamber. You see there's a few stitches in the cornea, so it was not at all difficult to bring the lens into the anterior chamber and then removing the stitches and removing the lens. After removal of the lens or putting the lens in the anterior chamber, you go back, make sure that to complete your vitrectomy. It's very important to complete the vitrectomy properly and to remove the posterior hyaloid from the retina completely and to check the retinal periphery that there is no holes, no tears at all. This is very important. After completing the vitrectomy, making sure that the retinal periphery is sound, there is nothing, no injury, you go back to the original problem of removing the IOL. Now, as I told you, there was no problem in removing this IOL. You just remove the stitches and pull the IOL out. Now, in treating aphakia, you have a lot of choices to do. Do whatever you do, master. This is the best. In this case, in fact, I went to the easy choice. After removing the IOL, I did a PI with the cutter, and then I put an anterior chamber IOL. It worked very well. Still, you can correct aphakia by putting an anterior chamber IOL. Now, this is another case. Right. This is another case of subluxated or dislocated IOL. I have to remove IOL. Now, when the IOL is acrylic or silicone, in fact, I prefer to cut the IOL into two halves and remove it. I know that some of my colleagues, they like to roll the IOL in a forceps, over a forceps and remove it. but I still prefer to cut the IOL inside the eye. I guess that this is the less traumatic way of removal of the IOL. Now you have to use a special scissor with a serrated edge to keep the lens not moving, and you have to be careful not to injure the iris or to injure the capsule when you are doing this step. After cutting the IOL into two halves, you can remove it easily. It's not difficult at all to remove it through this small retinal or corneal wound. In this case, in fact, after I did remove the lens, I found that there was an intact capsule. Whenever you have an intact anterior capsule, you can put a three-piece lens in the sulcus. And this is what I did. I put a three-piece lens in the sulcus for this patient, and it worked very well. So whenever you have, you can see that there is a beautiful anterior capsule. It's very sound and intact, and you can fix a three-piece IOL inside this eye. This is another way of treating aphakia in these cases. Well, the problem is if the patient has no capsule, what to do? If the patient has no capsule, as in this case, you have more than one option. I told you, you can use the anterior chamber IOL, you can use artisan lens. I used to suture lens before, but now I'm doing a Yamani technique. This is a case of Yamani technique. You have to make sure that the haptic can enter the lumen of your needle before doing that. You don't need surprises after injecting the lens inside the eye. So after I remove the dropped IOL in this patient, putting Helon is very important. Keeping the pressure inside the eye. You have to keep the globe intact. You have to have some pressure inside the globe to do a Yamani technique. If you have a hypotony, it will be a mess. So we, as a retinal surgeon, maybe we have the advantage of the irrigating cannula, the posterior part of the eye, where you can keep the pressure inside the eye, especially if you do a tunnel, scleral tunnel, you can keep the pressure inside the eye, and this is very good.
Madana, can we wrap up in 2 minutes?
Yeah, well, I'll finish. This
okay,
is
you finish. Thank you so much.
This is the last.
That's beautiful.
So, what we do in Yamani technique is we go 2.5 millimeter away from the limbus, and then we put the lens and we create a tunnel in the sclera using the 30 gauge needle, and I'm doing the tunnel now inside the sclera for almost 2.5 millimeter, and then you go inside the eye and you fix the haptic of the IOL inside the lumen of the lens, and you pull it. It's very tricky. It's not difficult at all to fix the first haptic. Now, putting the haptic inside the lumen, and you have to make sure that there is enough haptic inside the lumen before pulling. You don't want to lose the haptic. You will go into trouble. So this is you pull your haptic and then you cauterize it, and you do the same in the second haptic. fixing the second haptic, telling the truth, is more tricky than the first haptic. But whenever you're mastering the technique, it becomes a routine for you. I know I told you that you can do this with artisan lens. You can do it by suturing the lens. You can do whatever you are mastering, you can do. We can start the discussion if you want. While
Yeah,
people
no, I think this is great. This is a 30 gauge needle for the audience. The standard 30 gauge needle. This is a 30 gauge needle.
So you'll postpone the discussion, or you want to?
No, I think we'll have to move on because of the number of videos.
Okay,
The question, is this a 30 gauge needle?
This is a 30 gauge
This
needle.
is a 30 gauge
And even you can use, there's a 27 gauge needle that can be used. You can use both. Yes. I have both, in fact, and I tried both. But I think using the 30 gauge needle is easier to create the scleral tunnel than the 27 gauge.
Very nice. Thank you so much.
Thank
We'll
you very
see if we can catch up, but I think it will be difficult to catch up with. Dr. Vivek is our next speaker, and then can we go to Dr. Vivek first? Yes, please. For the panelists here, any quick points as our next speaker connects about correction of aphakia? What do you do, Karsten?
Yeah, I also tend, I mean, we did a lot of artisan lenses in the past, but now when I have a three-piece lens, I even try to keep the eye inside the eye because you don't have the, you know what kind of refraction he has, and this is a very safe and has become a very nice procedure. It's also quick and forward.
Yeah, so usually I do the Gore-Tex suture for the Aquiros lens from Bush & Lomb. The only disadvantage is it is hydrophilic, and if some complication happens, that maybe that gas will touch and affect the lens. But for me, I didn't face any case yet like this.
Thank you. We'll get back to you, Dr. Rao. I think Dr. Vivek, if you can speak.
Right. Thank you. Thank you. Good afternoon. Thank you, MUM. Thank you, the chair, for having me here. There is a small change in my topic. It's not aqueous misdirection, but I'll be speaking on posterior segment endoscopy for endophthalmitis. I have no financial disclosures here. So we tend to face endophthalmitis many a times in situations where, for varied reasons, the corneal clarity is not up to the mark to allow us a good posterior segment intervention. That could either be an edematous cornea secondary to trauma, or a keratitis and a corneal ulcer. So what are the approaches that we can have here for posterior segment management? Either we can only give intravitreal injections, which would be a simple and quick approach, but there would be no vitreous clearance here. You cannot assess the retina up front, and the management can often be suboptimal. Or we can go ahead and do a keratoplasty and a vitrectomy, achieve an extensive vitreous clearance, be able to see the retina on table, but graft haze would still be an issue. There would be graft rejection down the line, and also it's a very laborious process. You require the cornea colleague to come in, and it becomes a very extensive affair. Or you could go ahead and do a temporary keratoprosthesis and a vitrectomy. Little better clarity because of the artificial glass nature of the keratoprosthesis, but still a laborious nature, large team, and the fact that at the end of the surgery you need to replace the keratoprosthesis again with a cornea becomes a big affair. Herein is where endoscopy has a good role. It allows you a good vitreous clearance. The retina can be assessed on table. Corneal surgeon is not required, and it allows for the natural corneal clearance. You may have the corneal issue which is temporary. So if you can bypass that and deal with your posterior segment, naturally the cornea may clear down the line. But there will always be a learning curve because this is something which is not traditionally taught in training programs. We use the Endoptics system at our institute, no financial interest there. It is a composite probe with a light pipe, a camera and a laser inbuilt, available both as 20 gauge and 23 gauge, and also in straight as well as the curved configuration, the curved one being used for glaucoma management for endoscopic cyclophotocoagulation. We'll run through quick 3 case scenarios where we apply this for posterior segment management. So the first is a 9-year-old female, history of trauma with a wire 6 days prior to presentation. history of corneal intervention elsewhere 3 days ago, and presenting vision of PLPR accurate. So we can see a repaired corneal tear, some tissue adhesive in place. We can see an immune stromal ring there. Posterior segment showing lot of echoes. So primarily this patient underwent a vitreous stap which grew Enterobacter species. So if you put the entire scenario together, you have a post-trauma etiology, a gram-negative organism, a young patient, and no posterior segment view. So something where you really need to clear out the vitreous cavity, but you're not able to do it conventionally. So this is where if you enter using an endoscope, you are able to see the exudates much more clearly as it is visible on the screen. And effectively, I am able to clear the entire cavity and reach right up to the retina. So you'll see here that the macula disc are largely visible and you can clear out the entire cavity well. So remember what the cornea was looking like, and this is what we end down the line with post-operative steroids, antibiotics. So we have allowed this cornea to clear out naturally. The posterior segment has settled down, and visual acuity of 6/18 N12 for what we began with is really good for this girl. Second scenario, a 52-year-old male, reduced vision in the left eye along with progressive whiteness. Presenting vision was PLPR inaccurate, was on topical antifungal and antibiotic drops, and was advised evisceration elsewhere when the patient came to us for a second opinion. So the eye had a cornea which was melting, lot of infiltrate in the cornea, and in our emergency room, a tissue adhesive and bandage contact lens was done to maintain a tectonic globe integrity. Posterior segment, as you see, had lot of echoes. So going by the look, going by the fact that already an opinion for evisceration was there, patient is in extreme pain and is okay with the fact that, the eye would be removed if it gives him comfort. We still thought, let us give it a chance and see what the posterior segment looks like on table. So this case actually was a sort of a learning for me that many a times B-scan overestimates the problem in the posterior segment, and not everything that looks on B-scan is infective. So look at the posterior segment here. Look at what the B-scan was, look at what the posterior segment is. There is hardly any involvement of the posterior segment. So if this eye gets eviscerated, this is something which possibly is not correct. So the posterior segment was so good that the cornea person was called up on table, and an immediate keratoplasty was done. Post-op week 1, post-op month 1, post-op 3 months, vision of 2200. So someone who possibly could have got eviscerated at one end is now having an eye which is really functional. Time permitting, the last case, this was a part of a cluster endophthalmitis that was referred to us. Again, you can see the cornea has an extreme haze. Here what you can possibly do is just a vitreous tap, or you will have to do one of those extreme procedures that I mentioned. Going ahead, we entered this eye endoscopically, which allowed us to clear out all the exudates effectively and reach the entire retinal surface. I will skip the rest of the video because it's similar to video 1. Just letting you know that this eye was then filled with silicone oil because a couple of breaks were noted on table. And then you come back to perform your silicone oil removal, and as an elective process have the cornea surgeon come in and replace this cornea with a keratoplasty. So herein you are doing a keratoplasty in an eye which is no longer quote-unquote hot. It is an eye which has settled down, and that helps your graft to take up better, and the chances that this will reject down the line become lesser. So the clarity was sort of good enough for me to give a visualization on table, and here you can see that the retina was largely doing fine in the post-keratoplasty scenario. So we have collated our experience of endoscopy in endophthalmitis and realized that the evisceration rates whenever the keratitis is present with endophthalmitis, as compared to a literature of 25 to 30% incidence in our subset, had come down to 3%. We've also put across work where we've shown that if you do a prompt endoscopy in an eye which otherwise has corneal edema, that allows the cornea to settle down, and you actually do not require a corneal intervention down the line at all. And even if you do require and do this keratoplasty in a deferred manner, you are likely to have the cornea that survives much longer than what it would have if it would have been done primarily. This is one article where we have collated the entire review of the intraocular endoscopy knowledge. So in conclusion, anterior segment trauma and endophthalmitis both can have an hazy anterior segment. Conventionally, posterior segment access can be achieved by a K-Pro or a keratoplasty to allow a vitrectomy. But an endoscopic approach will circumvent this necessity and avoid unnecessary keratoplasties and also allow for a natural resolution of the opacity in appropriate cases. So thank you so much for your kind attention, and I don't know if you have questions. Time for questions. Yeah.
Thank you.
Thank you.
You can come here and sit next to me as we connect. We can ask you a few questions and save the time. So we'll go with Dr. Kakan and then Dr. Habib. We're just trying to get around. Come and sit next to me here, if you don't mind, so we can use the time. So a quick question here. So the problem with the endoscopy is the resolution. You use 23 gauge. Have you tried the 19 gauge? Can we have a short answer so we can have more questions?
Yeah, so I largely use 20 gauge now because the 23 gauge, though convenient to enter with sutureless entries, the camera size is so small that you have a very compromised visualization. So the 19 or the 20 gauge works much better.
Thank you. Let's ask our panelist here, any experience with endoscopy?
Well, I know this from Frank Koch from Frankfurt. He did a lot of studies with this, and I know his experience, and I can only congratulate you on your results. So I think I haven't done it myself, but I think it's a feasible approach, and we should continue with this.
For me, I don't do the endoscopy. For cases like this, I use the Eckert corneal prosthesis, and sometimes if I don't have the graft, I use the same cornea and I postpone the.
No, I don't have any experience, but excellent videos, and I think there's a very fair point of using endoscopes when patients have corneal issues. Excellent videos again. Thank you.
So next speaker is Dr. Kakan speaking about anti-vitrectomy. Thank you so much, Hussein.
Thank you so much, Ahmed, and thank you, Miyom, for inviting for this talk. Before going for the talk, can I put the same question? So how many are doing the anterior vitrectomy through the limbal approach? Can they raise the hand? So it's 5, 6 people. And how many of us is doing vitrectomy through pars plana? 1, 2, 3, 4. So 5. Mostly the VR surgeons. So we are talking about the problem that facing the anterior segment surgeons also. So it's not easy to have all these things. So I will go through for the both part of the world, the anterior segment surgeons and for the retinal surgeons. So anterior vitrectomy from the pars plana approach. Usually the vitreous loss is after the posterior capsule rupture. In many instances with the torn posterior capsule, it is possible to avoid the rupturing the hyaloid face. That's the most important thing, that you should avoid to rupturing the hyaloid face. So what happens whenever we do have the posterior capsule rupture, the surgeons, whether it's anterior segment surgeon or posterior segment surgeon, he is in a hurry to withdraw the phaco probe. And that's the biggest mistake that the surgeon makes at that time. Actually, he shouldn't have withdrawn, he should keep the pressure inside the eye and fill the eye with the dispersive or viscoelastic. Because removal of the tip abruptly unplugs the incision and allows the anterior chamber to collapse. The sudden posterior pressure gradient rupture the intact hyaloid. That's the problem where the problem starts. So one must often rely upon indirect clues. How you can understand that I am having the posterior capsule rupture is the sudden deepening of the anterior chamber. This sign can be recognized easily, but the second sign is much more easier, that you are unable to rotate that cataractous lens that you were rotating very easily in the start of the surgery. And that's the biggest sign. You having difficulty in rotating that cataractous lens. That's the most important sign that you can have at that time. So I will just share a video. So this is normal routine cataract surgery going on. Posterior subcapsular cataract surgeon is happy doing the basic surgery. He has done the rexes, everything. He is doing the rexes, and here he will do the routine phaco emulsification. It is NS1, NS2 cataract, and phaco is done. He is calm and quiet. Few cortical material there. So here he recognized something and he wants to visualize the posterior capsule, but the things has been started not good. So he's removing the cortical because the surgeon has recognized that something is not good behind these few chunks of the lenses. So here he saw it and what he did wrong. Without putting any viscoelastic, he just withdraw the probe and you will see clearly what I was mentioning is happening here. You can see whole the anterior hyoid is abrupting like a volcano into the anterior chamber. Now he is putting some viscoelastic there and trying to maintain the integrity of anterior hyoid, but that complications has enlarged the posterior capsule. This undesirable cascade of events can be avoided by the filling of the anterior chamber, the viscoelastic, prior to removing the phaco tip. That's the main key. A viscoelastic is injected through the side port. Opening, the surgeon moves the foot pedal position onto the zero. So if we get the nucleus drop, early recognition of posterior capsule rupture is often the key to avoiding the drop nucleus. The similar situation you have to recognize is it is much easier to remove the nucleus while it's remain into the anterior in the capsular bag or anterior to the capsule, because the subsequent instrumentation may end up in the drop of the nucleus. So these are the few steps that anybody can do, but for these steps you may have a skill of going through the pars plana approach. So you can insert the trocar cannula and inject the viscoelastic behind the ruptured capsule like this. So in practically it looks very easy that you inject it behind it, but it's not easy when you are having this problem, because most of the nucleus drops happens when the patient have a small rhexis. When you have a small rhexis, it's very difficult to bring the nucleus into the anterior chamber or anterior to the anterior capsule. So it's not easy at that time. Then you keep on pushing and viscoelastic and bring the nucleus chunks into the anterior chamber. Similar problems you may get the opening of the wound from the limbal or corneal wound. You may have a high pressure and gets the cornea edematous. So multiple things are happening at this time because the surgeon is exhausted and the patient is not behaving normally even if he knows that he has a complication. So next step is here. Here I usually prefer, you see, if I get this pointer, no, it's not visible. So I will show. So the viscoelastics making the two chamber intact. This is the anterior chamber and vitreous cavity. So basically you are achieving the two chambers separately with the viscoelastic. So I will start from again this video and here you will see. So surgeon did the same thing and he is putting the viscoelastic, trying to separate the anterior chamber from the posterior segment. With the Simcoe cannula, he's extracting the peripheral cortical lens matter, but the posterior capsule rupture is extending with each and every step of the surgeon.
Kakan, 1 minute.
Sorry?
1 minute.
1 minute. So in this case here, you can see that at the end, surgeons was kept on doing, and he is doing the vitrectomy through the limbal approach. The thing here is with the viscoelastic, he got some vitreous into the anterior chamber, but he cut it at the end. He has a good filled anterior chamber and he is inserting the foldable intraocular lens in the bag implantation in this case. So this is basically is how you approach to the limbal incision. Here is how you approach the, just 1 second. So through the pars plana. So this is a 20-second video. The thing here is the patient is under topical anesthesia. It's not easy to insert the trocars. How you will augment? Patient knows that I am having surgery. The anterior segment knows that he is in trouble. So things are not easy, and getting the VR surgeon at the time and having the trocar inside the eye with the drop nucleus with the posterior capsule rupture for the anterior vitrectomy, it's not easy. So here the surgeon was in difficult condition. He did anterior vitrectomy. His whole nucleus is lying into the mid-vitreous cavity. The other surgeon just accompanied him and he just put the triamcinolone to confirm whether there is a vitreous or not. So he is doing good and removing all the vitreous from the anterior chamber.
I'm sorry, we'll have to stop here. Any concluding remark?
Sorry?
Any concluding remark? We'll have to stop here for the sake of time. Any concluding remark? Can
Yes,
you conclude?
concluding remarks is that it's not always easy to put the trocar when you are having a posterior capsule rupture. And it's very easy to say that you can go through the pars plana, but think about the situation when you have a posterior capsule rupture with the drop nucleus and patient is under the topical anesthesia. It's not easy, and patient knows that something bad has happened, and surgeon knows that something is going to bad and worse. So limbal approach is not as bad if you manage the anterior hyaloid with the viscoelastic abruptly and promptly, sparing that you have a viscot in the anterior chamber. Then it's bit safe. I'm not good for anterior chamber maintainer. I rather will use the direct flow from the Simcoe cannula or other cannula, because anterior chamber maintainer also damages with the push and pull. Thank you so much for kind attention. If you will have question, I am here after the session too.
You can come and sit next to us. Thank you, Dr. Devek. Kakan, come and sit here. We can ask you a question until Dr. Habib sets up. And Carson, I think you can follow Dr. Habib. We're trying to just group the cases together. So for the anti-segment surgeon, just in a quick one, pars plana or limbal, which one you would suggest?
For anterior segment surgeon, if he recognizes the complication quickly and he doesn't remove his probe and fills the eye with the dispersive visco to keep the anterior hyaloid intact, then the limbal approach can be done.
All right, thank you so much. Okay, Dr. Habib is speaking about intraocular perforation during local anesthesia.
Hello, everyone. I would like to thank the committee for this invitation, and I would like to share with you our experience with intraocular perforation during local anesthesia. The needle perforation has been reported with incidence up to 1.3%. The risk factors are the retrobulbar anesthesia, high axial myopia and posterior staphyloma of the eye, uncooperative patient, and multiple injection attempts. So the complications usually are vitreous hemorrhage, which is the most common, retinal breaks, RD, endophthalmitis, and to a lesser extent, vascular occlusion and macular holes. So one to suspect that there has been a needle perforation in this eye, first with the anesthesiologist, if he finds that there is hypotony with the eye or a sharp increase in the IOP if he injected into the eye. Also, there's a part on you if you find there's loss of red reflex. The red reflex is a bit dark red. Anything off about the case, you should be suspecting and putting the perforation possibility in your head. Also the subluxation of the lens, we have seen some of the cases like that, which wasn't present before. So there are patterns of reactions of doctors to these kind of situations. The not so wise doctor, those make the wise decision, not so wise, that to wait and see after the diagnosing of hemorrhage. For example, this case has been waiting and seeing for 2 months. As you can see, there is organized vitreous hemorrhage, and you cannot see the retina. It was diagnosed as RD, but actually it was a dense vitreous hemorrhage with posterior hyaloid thickened. As you can see here, that the place of perforation of the injury is at the posterior pole and near the disc. Usually in this kind of cases, an epiretinal membrane forms and it is usually thick. In this kind of cases, I just peel the extensions of the membrane and collect it over the site of entry. And I don't prefer to remove the epiretinal membrane from over the site of entry in case there's a break or something more. So I just pull the extensions of the membrane from over the retina or the macula and just shave over the site of entry. Also, if this is an old membrane and it is extending over the macula, I usually do an eye lamp peeling, not only for the eye lamp peeling, but to ensure that the PVR over the macula is removed. The other pattern is the not so forward doctor. Those convince the patient that the healing process, that it's a healing process, and they just give anti-inflammatory drugs until the patient is fed up and goes to another doctor. This was referred to me by another doctor who was diagnosing endophthalmitis. This patient had hypopenia, which with antibiotics and anti-inflammatories improved, but as you can see, there is vitreous hemorrhage and actually severe inflammation and maybe low-grade infection. This has been there for 2 weeks. He did the operation 2 weeks before. And after removing the hemorrhage, I usually take good care to do the PVD very slowly, because the site of injection or the site of injury, at this site, the PVD cannot be done and the vitreous should not be pulled over. So I just, as the other case, trim around it and over it and just do a barrage. And this case was put on gas and it went well, alhamdulillah. And this is the best pattern, the not so alone doctor. These kind of doctors, they have a VR specialist at the team, and they don't hesitate to refer immediately to the VR specialist. This is it's the first day post-operative. This is the day after the incident happened. And as you can see, there's fresh vitreous hemorrhage and multiple injury sites on the retina. And it's usually, there's an entry site peripheral and multiple sites in the posterior pole. Here you can see 3 breaks and subretinal hemorrhage. But don't forget to check the periphery, as there's usually an entry site on the peripheral retina. This case was managed also with laser barrage around the breaks, but here I elected to put silicone because the retinal breaks had ragged edges, so I decided to put silicone and it went fine, alhamdulillah. So in our experience, our best results were achieved with early intervention, attached retina, spared macula, and if we can put gas tamponade, things go well. But if we put silicone, we stay for more than 2 months. Usually there is an epiretinal membrane that forms and it's usually thick. So you should expect this outcome. So what to do if you expect a perforation? Please don't proceed with surgery. If you find anything suspicious, stop with the surgery, don't proceed, and examine the fundus thoroughly. If a break is found and there's a clear media, you should laser. If vitreous hemorrhage is present, refer to a VR surgeon, and in my opinion, immediate intervention is my choice. If a retinal detachment is present, refer to a VR specialist also for the postoperative vitrectomy. So in conclusion, needle perforation can happen even with the best hands. Be mindful of the possibility. You should have a look on the red reflex before starting the surgery. If there's anything off, don't start it, because if you start it, it's your responsibility. So, and if a needle perforation occurs, immediately deal with it or refer to a VR specialist. Thank you.
Thank you so much. Can you come and sit for discussion as Dr. Karsten connect? Yes. Can we have help here, please? Can we have help connecting?
Shouldn't you say, shouldn't you present?
And Heidi, I was trying to save time. Do you want to take your?
Take mine.
So, can we have a show of hand of those who operate cataract surgery under retrobulbar or peribulbar? Peribulbar? Okay. Peribulbar, okay. Please.
You notice that most or all of the injuries were above the disc or the macula. Why? Because the patient is usually afraid and he looks up while you are doing the injection. So to avoid this, make the patient fix straight and use a peribulbar needle rather than a long retrobulbar needle to avoid such an injury.
Thank you so much. So Ahmed, a quick question here, and then we'll ask also the panelists. So you prefer gas or oil in these cases? And it's a good tip not to peel over the entry side, to leave the vitreous or the membranes to close it. So gas or oil, if you have the preference?
If I have the choice, gas, of course.
And Dr. Abdelaziz?
Gas, yeah, because I'm afraid if it's fresh like the case that the silicone oil is, it will go outside. Yeah.
Not many, but I think gas would be my tamponade of choice. But I have a point here. What happens if the patient has a mature cataract and you suspect a perforation? In that kind of scenario, I think it's rather important to go ahead and do the phaco, because unless you remove the cataract, you're not going to, if you're an anti-segment surgeon, you want to go ahead and do a phaco and then refer it to a VR, because that's the only way you're going to diagnose that the patient has a perforation or so.
Thank you so much. And I think avoidance is the best, so topical anesthesia and subtenons for cataract surgery might be the best. Okay, our next speaker is Dr. Carsten Meyer from Switzerland, and Dr. Carsten is speaking to us about drop nucleus. Thank you.
Well, I'd like to thank the organizers for their kind invitation, and I think drop nucleus is a very nice topic where you combine anterior posterior segment surgery. So when I get a referral with a drop nucleus, first of all, I want to know what has really happened, and we can differentiate. Was this during an acute blunt trauma? Was it spontaneous in a pseudo-exfoliation syndrome, Marfan syndrome? So then usually the entire lens is ruptured into the vitrectomy, into the vitreous. However, we also saw numerous examples about posterior capsular rupture where either the entire nucleus is dropped into the vitreous cavity or just particles during phacoemulsification. Treatment is mandatory, and there's no doubt that this belongs into a surgeon's, vitreoretinal surgeon's hand, because you can induce much more harm if you damage parts to the retina. When the entire lens is dropped into the nucleus, you have plenty of time. Probably most of us have seen a rupture of an entire lens into the vitreous cavity. I've seen recently a patient who had this lens for 10 years in the vitreous cavity. There was no elevated eye pressure, no inflammation, so this is not an emergency case. However, for example, in Marfan syndrome, where you might face serious retinal detachments as complications, you needed an experienced vitreoretinal surgeon who takes care with the lens removal. When the capsule ruptures during hydrodissection, you may find an entire nucleus on the fundus, or it can happen during phacoemulsification. Here you can subdivide it. Is it just a soft particle which you can easily aspirate, or was it a hard, larger nucleus? So here I show you a case from a colleague of mine where already here the first part ruptured into the vitreous cavity. He continued phaco, so actually the phaco tip was blocked. He tried to aspirate it, and now he loses the second part. And while he was removing, you see already that the vitreous is coming out of his tunnel, so you have to go to vitrectomy. You have to clear the obscured view to the fundus, and once you have cleared it, then you go into the vitrectomy mode, and I tend to clear the capsule with my vitrectomy probe. With aspiration, you can nicely do it. I don't like this approach where this was just a huge lens particle, and it's always bouncing on his retina surface, and this can induce damage to the retina surface, and it takes a long time. So the bottom line here is when capsular ruptures, stop your phaco, start with a vitrectomy. So you need an experienced vitreoretinal surgeon, because once the phaco probe is clotted, you can't remove any more vitreous, and you induce traction on the retina with tear formation. So during vitrectomy, you see if you do this a day later, then usually the lens is already swollen a little bit, and it's easier to aspirate. So small particles are easy to be aspirated after a complete vitrectomy. We already discussed this. Should you remove the vitreous from the anterior segment or posterior segment? If it's just a capsular rupture by the end of phacoemulsification, you can easily aspirate the vitreous, clean the sulcus, and implant a second IOL. However, I tend as a vitreous surgeon to prefer the vitreous approach, because I see so many patients who after successful implantation of a lens complain about floaters, or you have still remnants that you didn't find in the vitreous cavity and the patient have elevated eye pressures. So I like to remove all and clean the vitreous up to the base before I go in and implant a second lens. No? So here So via surgeon, it's really important that you clean the vitreous, and especially we have seen this already, the vitreous base, especially when you get a referral, you don't know how much the phaco physician has induced traction on the vitreous base, and I tend to do a meticulous cleaning of the vitreous base, because very frequently you see tears which may induce at a later stage a retinal break and retinal detachment. So for a vitrectomy cutter, for the removal of small parts, you can use a high aspiration with a low cutting rate. I prefer 23 gauge vitrectome because it's easier to aspirate larger particles. The light pipe can be used for assistance. So the benefit, it's faster, you don't have to use PFC. However, you have to make sure that the vitreous has been removed and that you don't induce traction and that you don't touch with your vitrectome the retina. So another way to remove the lens once you have removed the vitreous is, previously we used just the lens, the light pipe. You can poke it into the lens and you can use a fragmentome. But I think nowadays, I think that a phaco or ultrasound doesn't belong into the vitreous cavity, and it takes a longer period to emulsify the lens. You have numerous particles in the vitreous. You have frequently to suture the scleroptomy of your fragmentome, and therefore I have stopped this approach. So I tend to, in large lens particles, I go for the safest approach. I try to either to remove it in the mid-vitreous by applying some additional PFC, which has makes it safe so that you don't induce any traction on the retina surface. And if I can, I also want to finish my phacoemulsification as I intended to do. So once you have a rupture and a luxation of the lens, the dropped nucleus, I clean the capsular bag. I inject triamcinolone to visualize the vitreous. I clean the periphery. I inject Dicoline, and either I can aspirate it with a vitreous probe, but if it's too hard, I elevate it up to the posterior anterior segment. Oops, this was too fast. And then you can basically remove the vitreous with your phaco on top of the PFC bubble. Afterwards, you aspirate the PFC. You until the end. So the take-home message is, when you have a dropped nucleus, you have to have a person who takes care of it, who has a lot of experience. The greatest distance to the retina is the safest. So either remove it in the mid-vitreous by the assistance of PSC, with a vitreous cutter with the use of the light pipe, or move it into the anterior chamber and remove it with your phaco tip. In really rare cases, I've done recently one, it was just a black nucleus, and even with phaco you couldn't dissect the lens, and I had to use manual expression. Thank you very much.
Dr. Karsten, perhaps you can come back and sit here and we can have questions as Dr. Thanesis set up for the next talk, which is connected. It's about subretinal drop nucleus and many problems. So maybe a good time for questions until we set up. So you advocate using PFCL, right?
Yes, I think it's really a safe approach, especially in hard nuclei and when you have a large lens. When you just have remnants, as I showed you, it's easy to aspirate them with your vitrectomy cutter. But if I really have a solid big lens particle, I try to elevate it into the anterior chamber, and then you don't also have to switch back and forward. With a new machine, it's easier to switch between the phaco mode and the vitrectomy mode. But in older machines, it can be really cumbersome. Then the nurse has to set up. So it really takes longer, and therefore I prefer to do the vitrectomy, and if I cannot remove it completely, then I remove the rest by anterior segment phaco. And I don't have to suture the sclerotomy from the fragmentome or something else.
Yes, one last.
Can we have the presentation ready for Dr. Thanesis?
Okay.
Do you have your presentation there? Or
Yes, I think I do.
Okay, so shall we have, if you want to get it ready, Dr. Thanesis, maybe from the panelists here, do you use PFCL?
Yes, I use BFCL, but I use the fragmentome. I didn't take the nucleus to the anterior chamber. So DORC, they has advantage that you can go through the same 23 gauge and remove the trocar and do this one. I do prefer this one. And also I use the twin light. I use a bimanual, and it looked to me more easier than using the light bulb. Yeah.
Yeah, just
in very hard cataracts, I think PFCL is a good option. Sometimes I find when you're injecting PFCL, the lens gets pushed against the retina, and the PFCL bubble sometimes rides over it. So do you have any tips and tricks to make sure, because it's a convex surface, right, of the PFCL bubble, so always it tends to slide towards the periphery?
Just two quick comments.
If you do it slowly, and if you just shake it, then it maintains on top of the PFC bubble, or you can direct it with your light pipe. So, but I know it can be sometimes really cumbersome, so it's really between the wall of the eye wall, the retina, and the curvature of the PFC bubble.
I only cover the macula and just upper 2 mid periphery.
I have to ask you to apologize in a minute because I have uploaded my presentation.
We'll keep the discussion going.
And I'll have to check why it's not uploaded yet. Okay, thank you.
So maybe let's have a question from the audience, and if we get Dr. Khashab to set up, I think would be a proper use of time. Please, can we have a short question? And
just actually two quick comments on these patients. If you're using 25 gauge vitrectomy, and depending on the lens status, it's very difficult to emulsify it with a vitrector. I've used it multiple times, but I usually prefer fragmentome in this case, and just fragmenting the lens so fast that it won't be an issue with the time as far as suturing the sclerotomy. The second part is I really can't stress enough checking the vitreous, just like you showed, checking the peripheral vitreous, make sure there's a lot of, always I've seen lens material at the inferior part, sitting there at 6 o'clock, just sitting there, and this probably, if you don't remove it, you'd be having complications, chronic CME and that. So, and I've had a few cases of post complications like RD, and these develop severe aggressive PVR. Do you guys have comments on PVR following drop lenses and your management? Because I've had some cases that are very aggressive PVR.
Thank you so much. Okay, well, I think we need to move on for the sake of time. Our next speaker is Dr. Khashab, and he's speaking about combined phacoemulsification and vitrectomy surgery. They found it. Okay, we'll go back to you then, Dr. Singh. Sorry for this.
Okay, thanks a lot for the organizing committee to have me in this very interesting session. My talk would be a bit different. I'm talking about combined phaco with vitrectomy in diabetic retinopathy, vitreoretinal diseases, and cataract. Cataract is the most common comorbidity in majority of vitreoretinal diseases. Cataract progression status post-vitrectomy surgery is often the major risk to progressive visual recovery. Combined pars plana vitrectomy and phacoemulsification ideally blend surgical access and rapid, sustained visual rehabilitation. We have a lot of publications about combining the phacoemulsification with vitrectomy, whether in diabetics or without, starting since 1999, I think, and we have as early as this study in 2001. And then we have this meta-analysis of combined versus sequential phacoemulsification and pars plana vitrectomy. It showed that no significant differences were found in visual and refractive outcomes between combined and sequential cataract surgery and vitrectomy. The rate of complications if we are doing combined surgery is slightly higher for filamentous reaction if we combine phaco-vitrectomy, especially in diabetic retinopathy, but with proper management, I think this can be overcome. All of these are studies. I will just show a bit of videos. This is a patient with combined traction rhegmatogenous retinal detachment. As you can see here, this is the OCT, this is the image, and this is the video. Hopefully I'll be able to move it a bit further. Yeah, the trick in doing combined cataract and vitrectomy, I think, is creating the capsulorhexis to cover the whole of the optic of the lens, usually forming long tunnel for the main incision, and just putting the lens, which is definitely a hydrophobic lens, no hydrophilic lens, cleaning the capsule so that the visualization would be the best possible. And we can see that the stability of the lens is very good, covering the optic by the rhexis. Then this is actually a bimanual vitrectomy. This is a complicated traction rhegmatogenous retinal detachment case, doing peripheral vitrectomy, then managing the membranes. So I think combining both techniques together at the same procedure, I think will give us better access, even easier manipulation for the periphery of the retina in such complicated cases. You can clean all of the vitreous, whether anterior or posterior, anterior vitreous phase, not touching the lens, not be scared to touch the posterior capsule and creating a cataract later on. So these all are, in my hand, the technique of choice that I would rather do whenever there is cataract. So what if there was no cataract during the procedure, during the initial stage? I would not do combined cases like this one, but rather try to maintain the lens and the integrity of the lens. I'll just move on because of the... So this is the post-op image. It was silicone filled and then removal of the silicone oil. After this, the vision improved. This is actually the other eye of the same patient. Sorry for the quality. Still the same technique, phaco-vitrectomy. This is a patient, she was 56 years old, female patient, and she had loss of vision in both eyes. So dealing with such condition is always better to give early visual rehabilitation for such patient. bimanual technique for such aggressive traction rhegmatogenous retinal detachment is always my preferred choice.
This is a combined case, Ahmed?
Yes. Yeah. And always, whenever doing bimanual, try not to pull too much and to have a plane of cleavage. Here, for example, there was a bit of hemorrhage. I tried not to pull too much. I moved to another point so that I can give this a bit of time to settle and to clot, then to remove it from another angle. And whenever you are pulling and seeing the area of cutting, then you will be able to move on even easier. And dealing with the membrane in whole. I think for the sake of time, I will be able to skip. And this is a patient, actually, she was done elsewhere and then referred to me with recurrent retinal detachment with large macular hole and progression of the cataract. I did the cataract initially, then I went inside and removed, there was epiretinal membrane, and this was an interesting case because the macular hole was too large and there was an ILM peel, very good ILM peel actually done before, so I wasn't able to use the ILM to cover this macular hole, so I did free ILM flap. You can see after removal of this dual membrane blue that the membrane, the ILM was totally removed. There was multiple holes and tears. It was very large peel, so a good peel, but not good for me because I was not able to use this or to harvest the ILM and to create a flap to cover this macular hole. But eventually I did free flap, and this was the image after even removal of the silicone oil. And with that, I think I conclude.
That's great. Thank you so much.
Thanks a lot.
Ahmed, do you mind sitting here as we connect, to use the time as Dr. Thanasis connect? Any questions from the floor about combined cataract surgery? Any quick questions? Please, yes, go ahead for a quick question. Yes, please go ahead.
But if you have an extensive PVR that extends to the periphery, I usually even remove a clear lens because I need to clean the periphery of the vitreous.
That's a great point. So less is more unless you have to intervene. So maybe quick points here. We start from Dr. Rao as Dr. Thanasis connect. This is not the toque. Do you mind helping us to get his proper toque?
Do you mind put the right one again? I'm coming up and down all together. Sorry. I cannot fight it.
Can we get the right...
They're winning. They are winning. There's no way to fight it. I just showed them...
Do you have it on you or no? No.
I have it in there. I showed them what to do. I have to go back again.
بتهيألي عايزين حد بيتكلم هندي.
Can we please continue? I don't like to mess up.
Okay, well, I think let's continue with the discussion, or even we'll get to Dr. Thanisis with discussion. Hopefully you found the talk. Maybe a quick question, a quick point here. We're starting with Dr. Rao. Can you tell us 2 tips for the cataract surgery with vitrectomy? For example, small rexes, what do you suggest?
I think small rexes is necessary because there's a risk if you put in tamponade, the lens has a possibility of anterior displacement and you end up with pupillary capture. That's a good tip. The second thing is, I often tend to open the posterior capsule as well. I would do a posterior capsulotomy because, especially if I'm using gas or something, then you can avoid doing, the patient does not generally require a YAG laser later on. So you can end up, if you're putting gas, you can just go ahead and do a posterior capsulotomy as well at the same time.
Any 2 tips?
So yes, for keeping the IOL, usually I keep air bubble at the end of the surgery. Small, yeah, in the anterior chamber, yeah, very small, yeah. But I still have a concern if somebody know what is the solution for this posterior synechia. I know Klaus Eckert, he has special lenses and he do posterior capsule, but for me, I didn't do it. Any suggestion for this posterior synechia?
No, I've seen it rarely. Well, you know, I tend to have, the rexus shouldn't be too large that you don't have that it doesn't flip, especially when you have an air bubble inside the vitreous cavity by the end of surgery. And I tend to have my tunnel a little bit longer because it's just for the stability. But you don't have to suture it, and even I do usually in retinal detachment surgery where you have to combine it really a very heavy indentation, and in my hands the lens is really stable after phacoemulsification, and you don't have really to manipulate, you can really manipulate from the globe and there's no movement of the lens afterwards.
Dr. Kakan, you have a quick comment?
I have a quick comment. I tend to disagree about the small capsule rexis for vitrectomy and phaco. Because it depends on the choice of intraocular lens. If you use a multi-piece IOL, then you don't need a small rexis. And believe me, your small rexis doesn't stabilize your intraocular lens. It's rather induced posterior synechia with the more induction of the posterior synechia from the iris with the capsule rather with the iris with the lens. So you are, but by doing the small rexis, you are intending to prevent it, but you are enhancing this one. So it doesn't prevent your posterior synechia. Get a big rexis, 5 or 5.5, you will have a less synechia. Use multi-piece IOL, you will have a good stability. I mean, doing small rexis is of no logic to have a good stability. And keeping the air in the anterior chamber, I don't know how it will help.
Yeah, thank you, Kakan. Maybe can we have a quick point here? Okay, we'll get back to you, Dr. Hassan. But can we make the comments quick so we can move on? Dr. Saad, can you connect?
Rexus is 5 millimeter, not below 5. So to cover whole of the optic all around, not to have any place which is not covered by the rexus. Yeah. That's the meaning of small rexus, not smaller than that, not 4, for example. And long tunnel prevents, as you mentioned, and I think I agree totally about that. And you usually do not need to suture any of these lenses. I tend to disagree about whether it is 3-piece or 1-piece. Even 1-piece, it's very stable, as long as you put it right and you cover the whole optic with the rexus.
So one point regarding the post-op inflammation and posterior synechia formation. I get to use the intracameral dexamethasone in combined procedures, so this is decrease the risk of inflammation post-operatively and also decrease the risk of posterior synechia.
Okay, we have a quick comment here, Dr. Hassan, right? Do you want to say something?
So as a pearl for preventing posterior synechia, I do usually at the end of my combined cases inferior reticectomy with the vitrector, and that have solved major issues for me in reducing the pupillary block issues that you may face, and also posterior synechia. And I usually suture all my incisions with the 10-0 sutures, and that have helped keep the anterior chamber stable. And I wouldn't probably use air in the AC, because that kind of maybe dislodges the lens also as well.
Thank you so much. That's a great question. I think all are debatable, but small rexes, you want to keep the AC deep. Air in the AC is good in those three that works for them. I use it, and you want to make sure you have a long tunnel and keep the AC deep. Well, thank you so much. We'll move to Dr. Saad Wahib about zipper syndrome and precursor to GRT, GRD. Thank you, Dr. Wahib.
Thanks. Thank you, Ahmed, for the great invitation. And I'm sorry I came a little bit late. I couldn't join your esteemed panel. I came in and I went into the wrong room. So I was sitting in the cornea room, and everybody was looking at me, and they said, "What you doing here?" So I knew I was in the wrong room. Okay, so without further ado, let me start with this rare complication that we see sometimes preceding cataract surgery. I'll start with the case. This is a 35-year-old male, healthy, who came to see me. He used to be a moderate myope. He underwent uneventful refractive lens removal in both eyes, and he was doing pretty well, very good vision until he came 6 months down the road after the surgery with a macula on RD. I saw him, and I told him that you're going to have to go for surgery. So I'm just going to start the video to show you here the case. Initially, what I've noticed when I was doing this case, and I've seen a couple of these patients, they have a very opacified vitreous, and the vitreous base is posteriorly inserted. That doesn't look like the usual vitreous base that we usually see, that is usually more peripheral. And with this, you notice with the video that they have a run of holes that are along the same meridian, and these are multiple holes, and they're all tractional holes. You can see here there is actually both in attached and detached retina, and they are lined along the same line. And sometimes, because the detachment is very bullous, I actually have to use the light pipe to prevent the retina from coming. But what I have noticed in these patients is that these are very specific cases where you see these holes lined. First of all, they're posterior, they're along the same meridian, and the vitreous base is looking abnormal, and the holes are present both in attached and detached retina. So the surgery was concluded in the usual fashion. For the sake of time, I'm just going to pass into the next slide. I put silicone. He looked well. And again, you can see in post-silicone removal pictures how the holes are multiple on the side. And this is something that I've seen in these patients. There's a group of patients. A typical patient is usually a young male myopic. Okay, and these, on examination, as I said, they have abnormal vitreous. The vitreous is really abnormal, opacified, and these usually they have multiple holes, again, along the same meridian. You see these holes in usually both eyes. And I think once you see these patients, you have to worry, because the problem is these holes can coalesce with each other in a zipper fashion, and they will be the precursor of a giant retinal tear. I did not describe this. I was not the first one to see it. I think our great friend here, Dr. Athanasis, has seen this and described it before me. But I think it is something that we need to be very careful of. Now, if you look at the anatomy, the ora serrata, the vitreous base straddles the ora serrata 2 to 3 millimeter, and it's usually very peripheral. In these patients, the vitreous base is abnormal. It moves posterior, and it's actually wider. And I think it's very important to recognize this abnormality, because I think if he was recognized prior, maybe he would have been lasered. So the take-home message for me here is that, be careful of these young myopic patients, male specifically. You have to do a good peripheral exam, and what I do, I usually document my exam with fundus photography, preferably the Optos. I discuss with them all available options and the possible rate of complication. 1% of all phaco will develop retinal detachment, so I think they need to be aware of that. If I see the problem, I will pre-treat it with laser, and I think this is a condition that we need to be aware of, specifically retina surgeons. They are not common, but you will see them definitely. So I think this is you on the right side with the big eyes, and that is Zipper. So please, please be careful. Thank you. Sure. Why don't you come and do just talk about Zipper.
Okay. We can have a discussion on drop nucleus. Oh, here you go. Wow. We've made it.
Well, I call it Zipper because it's also in the attached retina. And if you don't care about it and you just fix the tear, you'll find yourself in trouble. And there's no way to remove the posterior base completely. There's no way. It's so much embedded. But I'm going from one to the other. Well, we had some surprises by doing that. First of all, I would like to invite you, because we're starting a new mission. This is to teach people how to face troubles. And it's done in Thessaloniki every year in July. So I'm asking the professors to come and teach, and everybody to come and teach, because nobody's a student anymore. Everybody knows everything through the internet. So we do this thing in Thessaloniki, so feel free to come the first week of July. And this is the result of what I call fishing. Fishing means that some surgeon decided to have a drop nucleus or some complications, and decided to put some trocars to do a posterior. And he put the trocars a little bit funny way behind. How can I start the video, please? Can you start the video? Okay, this is how I get into it. Another thing with Carson that we decide is we always use a chandelier light in drop nucleus. This is the #1 indication for chandelier lights, because you have two hands. And the other change we made is that we're using the right hand to have the forceps and the left hand with the vitrectomy. Here, what we saw a retinal detachment, but where is the nucleus? There's no nucleus. It's an eye. He promised me, he dropped the nucleus. And I just saw a retinal detachment. And then I saw this. Has a huge tear at the side of the trocar, and trying to look for the nucleus, I started, I don't know if I can have this, I started to check out to find out where is the nucleus. And then I saw I have to use a vacuum, 650 vacuum with a flute needle, to go inside searching for the nucleus. And this is the birth of a nucleus. And look what's going on. The hole, the tear, it's much smaller than the nucleus due to the elasticity. Look at that. And I think it was the first time that I've seen that. I don't know, a lot of people have seen that. And this is how we started the vacuum and how to do that. Now I'm stuck, because I need to remove it, and I have a huge hole, and I have a floating retina, and it's very difficult to use any tricks that I know of. And the trick that I know of is you never touch anything that's sitting on the surface of the retina. If you want to cut something, you have to go away from the surface. And you don't catch things while they are sitting on the surface, because you actually put the pressure against the retina also. So you have to lift it up. So we lift it up and start to chew it using the Bissoff technique, we call it. Right hand is using usually the forceps, because this is the one that you have to chop it up. Left hand is usually holding the lens in the middle of the eye with suction. Very low cutting rate, to 23 gauge, something like 200 And that's, you have to reverse it, and you have to remove all the vitreous that's around it, because if you have left any vitreous while you're pulling and pushing, then you might end up with another detachment. And now you have to crush it between your hands, divide and conquer. You see, it's becoming a technique now by manual crushing the nucleus. And if you need to, you can use fecal emulsification, but it's very dangerous in the retina. I don't like it either. And I think if I can avoid it, I try to avoid it all the time. The other issue is perfluorocarbon. You wouldn't inject perfluorocarbon in an eye like that, because the retina is opening the mouth to chew perfluorocarbon behind it. So there's no perfluorocarbon for this. Usually I'm not using perfluorocarbon because perfluorocarbon, when you start cutting the nucleus, it doesn't stay behind. Particles are sitting above, and then they go behind the perfluorocarbon. So perfluorocarbon is actually blocking the particles by pushing them against the retina. So I'm trying to avoid using perfluorocarbon also. So I give you the whole piece by piece to show you how little space you've got. You should not touch the retina detachment. You should not go anteriorly. You should not go posteriorly. You should stay in the middle and make it to small pieces. Another thing that people ask me is, when they have particles that they throw against the retina, what's going on? Nothing. If they go them by themselves and they hit the retina, they do nothing. If you push them or touch them while they're sitting on the retina, you make tears, you make bleeding, you make pigment dispersion behind the retina. So don't touch anything that's sitting in the retina. Suck it, bring it in the middle, and then chew it up. Otherwise, you are in trouble. And at the end, you need a little bit of patience. You finish up and you're left with a retina detachment that's the easiest part, okay? To fix a retina detachment. But see the space, and the complication possibly started because he put the 23 gauge stroker in the wrong position, something like 6-7 millimeters behind the cornea. And another issue is that these people, that they have complications, they have a lot of anxiety, you need to change the local anesthesia, you need to explain them that it's going to take much more time because you have an accident. They need to know under local to do that. And that's about it, and we can discuss it, but the thing that I'm always saying to my doctors, you are not allowed to fish anything that's behind the iris. When you have particles behind the iris, let them be. We'll do it. And put the lens. Don't be afraid to put the lens. If you clean the anterior chamber and no vitreous, and if you have a ledge to put a lens, put the lens, and we can remove everything from the back of the eye. Because the patient that has a lot of viscoelastic in the eye, probably the next day he has a white cornea with 60 millimeters of pressure. And this is what you like to avoid. Don't inject a full amount of viscoelastic into the eye, because you cannot remove it from the posterior chamber, and this is going also to raise the pressure. And you have the next day you have a painful eye, white cornea, and a patient who would like to kill you. Because you promised me a 10-minute surgery, and then you go home driving. And you got this result. Thank you very much for accepting me.
Do you have any experience with such cases, rare cases?
Yes, I have experience in retinal detachments with rhabdonoculus, but I don't have any experience with the nucleus behind the... I have silicone oil behind the retina, but this is the first time I see this by Dr. Tanasas. Thank you for this nice presentation.
I think same here. I have not had any experience of the lens behind the retina, but you often see patients with drop nuclei and detachments. So, Dr. Thanos, can you just describe how the procedure is done again? What is the forceps you're using in the other eye?
Due to reasons that your voice coming back to me, can you repeat the question without the microphone? No. What forceps? Always 23. 23 forceps. My nuclear surgery is always 23. 25 doesn't work. And remember, a very good tip is use your good hands to hold the forceps and the bad hand to hold the vitrectomy machine, because the vitrectomy does do a lot. So instead of supporting it with a light pipe, which is bending, another issue, if you bend the light pipe, then you cannot find a new one. So use this. Use forceps on the right hand, and vitrectomy on the right. The vitrectomy thing is low cutting rate, very big suction. You keep it in the middle of the eye, and then you squeeze it again. It's like force feeding. You squeeze it with the forceps, and the forceps are using two ways. When you close the forceps, they become knife, and you cut something soft. When you open and close, you chew them. So there's another trick to do that. Those small tips are unfortunately happen because we have hundreds of cases like that, because of my age. So don't grow up too quickly. Well, I'm using for these cases always silicon 5700, because I want to be sure that they will not have another complication. Gas can go behind very easily. Silicone oil, the hole doesn't have the surface tension to put silicone oil behind, because things are going behind when the surface tension of the hole is bigger than the surface tension of the thing that you're injecting. So you can use silicone oil freely, and then you can remove it and have a patient have a lens and everything like that. There's a lot of tricks and tips. That's why we made this TVRS school, Thessaloniki with the Retina Summer School, we do, because you cannot find them in the internet. This discussion cannot be in the internet. People are always, and they have a sign above my office, I'm not studied in Google. I have not studied in Google. A lot of people are opening the internet and they try to learn surgery. It's helpful tool, but the most helpful thing is what you're doing here, and being there with a Karsten is going to be next July, and he's going to sit on top of you and tell you, don't do that, don't do that. And those tips and tricks by you to other people are the one that make surgery great.
Thank you very much. Please,
okay, thank you so much. I'm conscious of time. I'll just move on to the important slides. So just for the cataract surgeons hearing us here or seeing us here, this is when you have a shallow AC and high pressure, this is what you need to think of. Is it a problem from pressure on the globe, so it's an external factors, or we're dealing with suprachoroidal hemorrhage, or we're dealing with aqueous misdirection, and it has to be in this order. So here, in this case, what actually the problem was that the drape was full and was pulling on the eye. Then the other one is suprachoroidal hemorrhage, and the message here I just want to give is do not do anterior vitrectomy, because what would happen is that the suprachoroidal hemorrhage is going to rupture if you do anterior vitrectomy. So the best thing to do is close, close, close. And then if it's not this or that and you examine the fundus, if you can see well, then it will be aqueous misdirection. And here you can do anterior vitrectomy if you need to, if you're not sure, close. For the sake of time, I just want to focus mainly on this. Suprachoroidal hemorrhage, you don't need to drain them unless it's very large and is painful, or the pressure is super high, or the kissing choroidals, because the retina is going to adhere together. So this is the old way of doing it, where you make the cuts and AC maintainer. A newer way is, as we all know, is using a trocar. Here, this is an exudative suprachoroidal effusion, but the same for hemorrhage, and use a trocar. And if you go about 7 millimeter back, you get better drainage. But I want to show you a very cool technique that I learned from one of my colleagues, which is really very cool, because these eyes are difficult, especially when you have very big hemorrhage. And this technique I'll show you here in a minute. Dr. Michael Mikhail, he's now in Rwanda, he was in the UK. But this is really very nice when you have big hemorrhage, what to do. So what they did is, in the preoperative area, they injected TPA 50 microgram, 0.1 mil, 7 millimeter, just with a needle. So you have this patient in the preoperative area, you inject that, going 7 millimeter with a 30 gauge or a 27 gauge needle, and you inject. And then you wait for 2 hours, you can go ahead and do a case or two, and give them Diamox for the pressure, which is going to go up more. Then here the TPA liquefied the blood, so it becomes very easy. So you do then an AC maintainer and a trocar, and it comes out very quickly. And I think this is a very clever technique, because it really makes things very simple, liquefies the blood. And we all know that these cases are difficult. And that's his video, and I'm waiting for the case to do that, but I think this would be a very nice way of doing it. Thank you so much. I will conclude here for the sake of time. Thank you. And thank you so much to our panelists and to the floor. Thank you. Thank you so much.
Thank you.